Welcome back. In this module, we will review the etiology, epidemiology, and transmission of trachoma. We will then discuss the clinical manifestations of this disease and the tests available for its diagnosis. Finally, we will present treatment options and preventative strategies. First, we will begin with 10 questions to begin our discussion on this topic. We will return to these questions at the end of the module to use the knowledge you have gained. Question number 1. What organism causes trachoma? Question number 2. What are the major risk factors for trachoma? Question number 3. Based on simplified WHO trachoma staging, what are the different stages of the disease? Question number 4. What is a pathognomonic clinical finding of early or active trachoma? Question number 5. What are the diagnostic criteria at the trachomatous follicular or TF stage? Question number 6. What are the diagnostic criteria at the trachomatous trichiasis stage or TT stage? Question number 7. How is trachoma usually diagnosed? Question number 8. What is the SAFE or SAFE strategy for treatment? Question number 9. What is the most effective antibiotic regimen for treatment? And finally, question number 10. What are the WHO guidelines for mass antibiotic therapy? We will begin with the etiology of trachoma. Trachoma is caused by Chlamydia trachomatis, a gram-negative anaerobic bacterium. Because it cannot synthesize its own ATP, Chlamydia trachomatis is an obligate intracellular organism. It has cytological tropism for columnar cells of the endocervical, urethral, and conjunctival epithelia. Here we can see the inclusion bodies indicative of those columnar epithelial cells infected with chlamydia. C. trachomatis has a 72-hour life cycle that progresses through the following stages. Stage 1. The elementary body, or EB, a metabolically inert, extracellular, small infectious particle found in secretions, attaches to the host cell membrane and is actively ingested by the host cell. Stage 2. Within 8 hours of EB ingestion, the reticulate body, or RB, forms and begins to exponentially multiply via binary fission within an intracytoplasmic vacuole called an inclusion body. The reticulate body is metabolically active and larger. Stage 3. Within 24 to 48 hours, reticulate bodies revert back to elementary bodies. When the host cell lyses, its EBs are released into the extracellular environment where they can further invade neighboring cells. Trachoma is a global disease with a marked disparity in prevalence. This map shows 53 countries in Africa, Asia, Central and South America, Australia, and the Middle East that are endemic for trachoma. Of these areas, 14 of the poorest countries are carrying more than 80% of the global trachoma burden. In 2002, the WHO reported that trachoma was responsible for approximately 15% of the total cases of blindness in Africa. Not surprisingly, the 2004 update showed that trachoma had infected more than 80 million people. Roughly 7 million of these individuals were estimated to be in the trichiasis stage, and another 1 million had already lost their vision. In contrast to other tropical diseases, trachoma often occurs in dry environments. It is prevalent in regions with poor sanitation and areas infested by flies, the vector for the disease. A mnemonic to remember the environmental risk factors of trachoma is the 6 Ds: dryness, dust, dirt, dung, discharge, and density, which stands for overcrowding. Trachoma occurs mostly in young children between 4 to 6 years of age who live in poor, resource-limited countries. Adult women are particularly susceptible because they spend the most time with children, who serve as reservoirs for the disease. In some endemic areas, the incidence of trachoma in adult women is 2 to 6 times higher than that of adult men. Blindness and scarring are more prevalent in adults. Eye discharge on the unwashed face of an uninfected child attracts flies such as muscosorbens that serve as vectors for C. trachomatis. During active trachoma, the child is highly contagious. The primary caregiver becomes infected as a result of close contact with the child's contaminated hands, face, or clothes. The presence of a dirty face with an odds ratio of 3.67 and the flies on the child's face with an odds ratio of 3.62 are the most strongly associated causes of trachoma transmission. The clinical manifestations of trachoma can be categorized into the active and cicatricial phases. The first episode, known as the active phase, usually occurs in young children. It is characterized by a mild, self-limited follicular inflammation in the superior tarsal conjunctiva. Although mucopurulent discharge may also be seen, the majority of these cases is asymptomatic. WHO grades patients in this phase of the disease based on the severity of the inflammation. The presence of 5 or more inflammatory follicles defines the follicular trachomatis stage, or the TF stage. Intense papillary hypertrophy and tarsal conjunctival thickening defines the intense trachomatis phase, or the TI phase. The cicatricial phase marks a persistent and recurrent trachoma infection that is more common in teenagers and young adults. Its severity and duration will determine the likelihood of progression to end-stage disease during adulthood. The WHO clinically grades patients in this phase based on the presence of intense scar formation or distortion of the upper eyelid, categorizing them as either trachomatis conjunctival scarring, or TS, or trachomatis trichiasis, TT, respectively. Grade 1 trachoma follicular inflammation, or TF, is shown here. This image shows a patient with trachomatis follicular conjunctivitis characterized by greater than or equal to 5 inflamed follicles located on the superior tarsal conjunctiva. This image is an example of Herbert's pits, a pathognomonic finding for trachoma during the acute phase. Herbert's pits are grossly visible, shallow impressions on the cornea due to pressure exerted on the cornea by the inflamed follicles. Grade 2 intense trachomatis inflammation, or TI, is shown here. This image shows visible deep tarsal vessels. The bottom image demonstrates intense inflammation of the upper eyelid with papillary hypertrophy and inflammatory thickening of the upper tarsal conjunctiva. Trachomatis conjunctival scarring, or TS, is characterized by grossly visible, progressive white lesions on the superior tarsal conjunctiva. In this image, we see the scars start as discrete, fine white lines that appear to traverse the conjunctiva. Eventually, these lines evolve into Arlt lines. Located close to the eyelid margin, as seen in this image. Contraction of the scars from the TS stage leads to inward traction of the eyelashes. This inward rotation puts the eyelashes in contact with the surface of the cornea. The eyelashes rub and ulcerate the corneal surface, leading to an intense corneal inflammation and scar formation as shown here. Key findings in this stage include the presence of at least one ingrown eyelash touching the globe or evidence of epilation. Trichiasis significantly increases the likelihood of blindness in patients with trachoma. Trichiasis is further divided into 1. Minor, which is 1 to 5 eyelashes touching the eye globe, and 2. Major, when more than 5 eyelashes are touching the eye globe. In patients with untreated trichiasis, an expanding pannus of intense, edematous, and highly vascularized tissue develops and progresses to corneal opacification as shown here. And finally, grade 5 is characterized by corneal opacification from continuous mechanical injuries which lead to visual impairment. Trachoma is usually diagnosed clinically. The simplified WHO trachoma staging system has a sensitivity of 53 to 75% and a specificity of 60 to 85%. Laboratory diagnostic methods for trachoma consist of cytology, culture, ELISA, PCR, and serology. Let's begin with cytology. Conjunctival swabs for evidence of inclusion bodies by Gamsa stain or direct fluorescent antibody or DFA are inexpensive tests with poor sensitivity of roughly 30%. The second is culture. Bacterial cultures are highly specific, 90%, but again have poor sensitivity. Number 3 is ELISA. Enzyme-linked immunosorbent assays for antigen detection are both sensitive, 70%, and specific, 99%, when compared to culture. The fourth is PCR. Polymerase chain reaction is the most reliable test with high sensitivity ranging from 98 to 100% and high specificity of 100%. However, it is also relatively expensive compared to the aforementioned modalities. The fifth is serology. The simplified WHO grading system remains the backbone of diagnosis of trachoma. In hyperendemic areas, the clinical diagnosis is reliable and easy to perform. On the other hand, in hypoendemic areas, PCR testing is recommended if available, given that clinical criteria alone may lead to overdiagnosis in settings where the disease is relatively rare. Global elimination of trachoma by 2020, or GET 2020, is an international effort led by the WHO to eliminate blinding trachoma from the world by 2020. The SAFE, or SAFE strategy, has been proven to be effective in reducing the incidence of blindness. This strategy includes surgery, antibiotics, facial cleanliness, and environmental improvement. The WHO grading strategy is useful in making decisions about treatment strategy. TF and TI stages are treated with antibiotic therapy and hygienic interventions. TT and TS stages require surgical intervention, and CO requires rehabilitative efforts to decrease the burden of blindness. Mass antibiotic treatment is the recommended modality for trachoma, given that the infection spreads rapidly in poorly hygienic regions. The WHO guidelines for antibiotic therapy recommend starting mass treatment for everyone in an endemic region where the prevalence for follicular trachoma among 1 to 9-year-old children is greater than 10%. Annual treatment should continue for at least 3 years and should continue until prevalence in that region decreases to less than 5%. When the initial prevalence of follicular trachoma in the region is between 5 and 10%, targeted antibiotic therapy should be administered to primary caregivers, households, and individuals who have intimate contact with young children and patients with active trachoma only. Patients with active trachoma should be given a single dose of azithromycin at 20 mg per kg or topical tetracycline 1% eye ointment twice a day for 6 weeks. Azithromycin is the drug of choice in the medical management of trachoma. Surgical treatment is recommended in cases of TS and TT that are refractory to medical therapy. The main purpose of surgery is to remove scar tissue, correct eyelid deformities, and limit the progressive damage to the cornea. Bilaminar tarsal rotation, or BTR, the most common surgical technique, moves the eyelids away from the cornea. In more advanced stages, corneal transplantation may be necessary. Unfortunately, post-operative recurrence of trichiasis is seen in 5 to 60% of cases. A combination of environmental improvement and education can enhance and prolong the effect of mass antibiotic treatment programs. Access to water and sanitation, fly control, and latrine construction have all been proven to reduce trachoma transmission. Let's turn now to the questions from the beginning of the module. Question number 1. What organism causes trachoma? The answer, Chlamydia trachomatis. Question number 2. What are the major risk factors for trachoma? The answer: extreme poverty, poor hygiene, overcrowding, rural areas, dry environments, women and children. Question number 3. Based on simplified WHO trachoma staging, what are the different stages of the disease? The answer: trachomatis follicular, intense trachomatis, trachoma scarring, trachoma trichiasis, and corneal opacity. Question number 4. What is a pathognomonic clinical finding of early or active trachoma? The answer: Herbert's pits are grossly visible, shallow impressions on the cornea. They are caused by the pressure exerted on the cornea by the inflamed follicles. Question number 5. What are the diagnostic criteria at the TF or trachomatis follicular stage? The answer: inflammation of greater or equal to 5 follicles on the superior tarsal conjunctiva. Question number 6. What are the diagnostic criteria of the TT or the trachomatis trichiasis stage? The answer is greater than or equal to 1 ingrown eyelash touching the eye and or evidence of epilation or loss of eyelash. Question number 7. How is trachoma usually diagnosed? The answer: it's a clinical diagnosis using the simplified WHO grading system. Question number 8. What is the SAFE or SAFE strategy for treatment? SAFE stands for surgery, antibiotics, facial cleanliness, and environmental improvement. Question number 9. What is the most effective antibiotic regimen for treatment? The answer here is a single dose of azithromycin dosed at 20 mg/kg. And lastly, question number 10. What are the WHO guidelines for mass antibiotic therapy? The answer is to start mass treatment for everyone in an endemic region when the prevalence of follicular trachoma among 1 to 9-year-old children is greater than 10%. And this concludes our module on trachoma. Appreciate your time.